We shall now go on to our next speaker, Dr. Saptagirish, who will be dealing on ocular inflammatory disorders and bring everything to relevance in this topic. Dr. Saptagirish is the head of the Department of Orbit and Oculoplasty, Shankara Eye Hospital, Bangalore, and is a Dean of Shankara Academy of Vision. On to you, Doctor.
Good evening, one and all, and thank you, Dr. Chitra, for the introduction and also inviting me for the sessions. Good evening, one and all. I'll be talking on idiopathic orbital inflammatory diseases. I'm sorry, my video, there's little bandwidth issue, so my video may not be playing. So what is IOID? It's a benign, non-infective inflammatory condition of the orbit without any identifiable local or systemic cause. Now, it was first described in 1905 by Birch and Hirschfield, and subsequently it was called as inflammatory pseudotumor by Umiker et al. The reason why they called it as inflammatory pseudotumor is because it mimicked a malignancy of the orbit, and they ultimately found out that it was actually inflammation. It occurs in all ages, both men and women, with a mean age of about 45 years. But of late, the incidence, they say that it's slightly more female preponderance. It is one of the second most common cause of proptosis, which follows thyroid eye disease, and is the third most common orbital disorder after thyroid eye disease and lymphoproliferative conditions. And it also accounts for about 17% of cases in children. Now, it has been classified according to its location, onset, and histopathology. According to the location, it's known as diffuse, anterior, posterior, trochleitis, myositis, or dacryoadenitis. There are other rare types, which is known as periscleritis, perineuritis, and a focal mass. According to onset, it may be acute, subacute, or chronic. And according to histopathology, it may be classified as lymphocytic, granulomatous, or sclerosing. Now, the diagnosis of pseudotumor is basically a diagnosis of exclusion. And initially, before the histopathology was available and before all the drugs and imaging was available, apart from thyroid eye disease, almost every condition of the orbit was labeled as pseudotumor. So looking at this, there's been a major study which published in JAMA Ophthalmology in 2017. It's called the Consensus on Diagnostic Criteria of IOID. They used a modified Delphi approach. It was done by the Orbit group, which is basically based out of USA. They tried to answer one basic question, whether they can frame a diagnostic criteria for defining IOID, which is actually a disorder by exclusion. And they found, the findings were that they used the modified Delphi consensus with 35 international experts across the world, mostly from USA and Europe, and a few representations from Southeast Asia. And they came with a set of clinical and radiological criteria for the diagnosis of IOID, supported by tissue biopsy for the non-myocytic construct, and also by a prompt clinical response to a trial of systemic steroids for the myocytic construct, which basically means that now they've classified the orbital IOID as either being myocytic, that is involving the muscle, or the non-myocytic, which is also involving the other structures. Now, this means that basically the criteria specific for the diagnosis of IOID is defined, and it includes tissue biopsy for lesions, which is not confined to the extraocular muscles. At the time of publication in 2017, the study was done between June to July 2016 to 2016 Jan and published in 2017. It was not tested in clinical practice, but after the study, most of surgeons are actually trying to put this clinical practice. The most accurate assessment of IOID is, according to them, is by clinical indicators, which I'll just specify shortly. Imaging studies, which is either the CT or the MRI, selected normal lab findings, and an incisional biopsy for non-myocytic IOID, and steroid responsiveness in myocytic IOID. So what are the clinical indicators? So the clinical presentation of IOID varies with the orbital tissue involved, with a degree of inflammation, associated fibrosis, and a mass effect. They may present with lid swelling, redness, ptosis, proptosis, and all the symptoms that we are aware of. But these symptoms which are mentioned here are in terms the source of the disease and largely are non-specific. So they came up with a specific set of symptoms and findings which is specific for IOID. The first one being orbital pain, which is the chief diagnostic criterion for IOID. 70% of patients with non-myocytic IOID actually have pain, which ranges from mild discomfort to very severe orbital and periorbital pain. And myocytic IOID is pain which is exacerbated in eye movements, usually on the gaze away from the action of the involved muscle. For example, if the lateral rectus is involved, the patient is trying to look in adduction, the patient is going to have pain. The onset is either acute or subacute, which is either days to weeks. Generally, the progression of IOI is a little slow. And there should be no history of orbital-related systemic diseases. So we should always exclude systemic diseases that may involve the orbit, like sarcoidosis and the IgG4-related diseases. Now, in relation to thyroid eye disease, it is not very strict to exclude thyroid eye disease because we know that patients can have, with thyroid eye disease, can also have concomitant orbital pseudotumor IOID. In relation to Crohn's and ulcerative colitis, it's not yet known whether it is a specific entity that involves the orbit or whether it's an epiphenomenon by itself. And pregnancy, orbital inflammation may arise during or after pregnancy, but the actual causal relationship is not yet established. Regarding the unilaterality, it is usually unilateral. And bilaterality is also common, it can happen, which may be simultaneous or sequential, which in the non-myocytic type is about 80 to 20%, and the myocytic type is about 14%. Usually, if the patient is presenting with bilateral disease, we should always look for a possibility of a systemic disease. And the age is generally between 10 to 75 years. There's been no racial differences which they found out across the studies, and there is no racial differences too, but they found a slight female preponderance. Now, regarding the CT and MRI studies, the all IOID lesions, whether the CT is done or whether there's an MRI done, they will enhance with contrast, and the amount of enhancement will depend upon the amount of edema which is there in the tissues. If the lacrimal gland is involved, there will be diffuse enlargement of both orbital as well as the palpebral lobes. And sometimes the swelling from the lacrimal gland can extend to the upper lid, the surrounding fat, and also the lateral rectus or the superior rectus muscles. And when it is orbital fat IOID, it's generally of the sclerosing type, it is usually located in the superlateral orbit. And in myocytic IOID, there's usually horizontal recti involved, and both the tendon and muscle are thickened, but we should understand that it is not very specific that tendon sparing inflammation may not occur. It can happen in tendon sparing can happen in myocytic IOID, and the converse, we can have tendon involvement also in thyroid eye diseases. Now, there was a major study which tried to differentiate an orbital lymphoma and IOID, because orbital lymphoma also mimics IOID and the other way around. So there was a study in China, Shanghai, which they tried to see if the MRI and the histogram analysis of ADC maps, which is nothing but the apparent diffusion coefficient on diffusion weighted imaging, to see if they could actually differentiate between a lymphoma and IOID. And their recommendations were that the IOID shows higher ADC values as compared to lymphoma, and lymphomas showed higher skewness and kurtosis compared to IOID. So which means that on a standard MRI, we can also differentiate between a lymphoma and a IOID. Now, the lab investigations, they include a huge repertoire of investigations. We need a basic blood cell count. We need to do an IgG4, an AC enzyme, and lysozyme. Now, when the lacrimal gland is solely involved, an anti-La estimation is important. Also, rheumatoid factor and the ACCPA and ACP and ANA. And when the extraocular muscles are solely involved, it's always better to do a thyroid profile because they could be concomitant. Now, histopathological evaluation of the biopsy generally shows a non-specific polymorphous infiltrate, and there may be presence of histiocytes and macrophages, and they may be actually focally organized as lymphoid follicles with a reactive germinal center. And immunohistochemistry is important because we've been thinking that IgG4 disease is very close to the way its orbital pseudotumor or IOID looks. But IgG4 positivity is not a prominent finding in IOID because it can happen in other orbital diseases too. But the ratio of IgG4 positive to total IgG plasma, if it is less than 40, it is significant. And a presence of IgG4 positive plasma cells of 30 or less is compatible with the diagnosis of IOID. So as they discussed that the diagnostic confirmation of non-myocytic IID is based on tissue biopsy, and of myocytic IOID is a trial of systemic steroids. Now this is different from our current practice wherein all types of IOIDs actually treated with steroids. So tissue biopsies are critical for the diagnosis. And the role of screening is also important, but inflammatory markers cannot be very diagnostic because they may be generally raised in other conditions also, along with the orbital inflammation. An autoimmune panel can be normal, and they just relate to the burden of the disease.
Time's up.
I can just take a couple of minutes, please. Just a minute, please. I just wind up.
Yeah.
The main backbone of treatment has been systemic corticosteroids, which is given for both biopsy-proven non-myocytic IOID as well as myocytic IOID at the dose of 1 milligram per kilogram and slowly tapered over 6 to 8 weeks. There have been studies where they've tried intraorbital triamcinolone also with good response, and you can also use oral NSAIDs for mild cases. Now, in refractory cases, radiation has a good control rates of about 65 to 75% when the 10 to 30 guidance dose, and anterior lesions can also be treated with electron beam. Steroid sparing agents can also be tried in patients who are not responding very well to oral steroids. They're limited. I mean, we can try methotrexate, azathioprine, T-cell inhibitors such as cyclosporine A, alkylating agents such as cyclophosphamide, also B lymphocyte inhibitors such as rituximab, TNF-alpha inhibitors like infliximab, adalimumab. And there's been a study now where they've shown tocilizumab, which is an anti-IL-6 receptor antibody, to also have good response in patients who are refractory to steroid therapy. I'm sorry I've taken a little more time, and I just conclude my presentation here. Thank you very much, and I thank Dr. Chitra for giving me this opportunity, and also AIOC and ARC.
Thanks, Dr. Saptagirish. It was a wonderful, very crisp talk, and there was a lot of learning from your talk. I have a question for Dr. Usha. What would be your management algorithm, doctor? Would you look at a trial of steroid for a couple of weeks and do biopsy for all cases, or would you differ?
This is Dr. Saptagirish. Given the time, you've done a fantastic job. The way we would have to go about, at least what we should be practicing is, ideally when you suspect an inflammation, the best option would be steroids, a trial of steroids. But in case it's not responding, I think we should stop steroids for a period of 1 month and subsequently go in for a biopsy. The tendency that most people have is to do a biopsy without stopping steroids, which would give us a false diagnosis, or it'll be misleading. So it's best to do a biopsy, and the biopsy also should be representative tissue. Again, it could be misleading. So we need to do a deep biopsy in such scenario, and it's very, very important that we have a good histopathologist to look at because there are many variants. It could be vasculitis, it could be just sclerosis, it could be granulomatous, many different types, and all of which could lead us to an answer. And the empty box, which started off with pseudotumor, is now gradually getting filled up with definitive diagnosis. And most often it's all ending up towards giving steroids. If they don't respond to steroids, we always have other newer agents now. So initially start off with steroids, non-responders go in for a biopsy after stopping steroids, and then go in for other agents. And radiation also helps to a certain extent too in some of the patients.
Ma'am, when do you decide on definitive management, like definitive debulking surgery?
Now, if we have a large lesion and it's compromising any of the functions, probably I would go in for debulking alongside. So that gives us some adequate tissue for us to look at the histopathology as well. So only when it's compromising, otherwise just a sample biopsy is adequate for us. Just do an incisional biopsy and come out. But the sample should be adequate enough to give us a diagnosis. If it's compromising on the basic functions, then probably we'll have to resort to debulking.
So will it increase the inflammation, madam? Like, do we have to step up our steroid dose when we do a debulking surgery, or?
we would be probably doing it in any case in any orbital surgeries. We would be giving high dose steroids, right, to control all the inflammation. So in that context, you will have to step up the steroid dose that you're giving immediate post-operative period.
So we shall go on to our next speaker. Thanks a lot, Dr. Usha, for your pearls.